Welcome to Pulmonology Read Aloud. This is Dr. Ansham Aneja Arora, and today's topic will be the new ERS statement on benign pleural effusions in adults. This statement paper was published in the ERJ in 2024, and it's a culmination of the various evidence that's available till 2024 on benign non-malignant pleural effusions. So let's look at this exhaustive review, which is very helpful. Let me start with the summary of this statement paper. It's actually a 215-page document which talks about non-malignant pleural effusions. And why they have chosen non-malignant pleural effusions is that they say that it outweighs the number of malignant effusions, and they are almost threefold higher than malignant pleural effusions. So these so-called benign effusions have to be dealt with seriously, and a lot of times they do not follow a benign course in many cases, and there are many complications, many uncertainties coming to the diagnosis, and often also high mortality rates. So they decided to have a multi-speciality collaborative effort across 11 countries and 3 continents, and systematic research was done of the medical literature to look at how to diagnose, especially transudative effusions, heart failure related effusions, hepatic hydrothorax effusions, renal failure effusions, asbestosis related effusions, post surgical effusions, and non specific effusions. Now, what's very important here to understand is that this statement excludes the management of pleural infection. So it does not deal with infection related effusions like TB pleural effusion or other pleural infections. And this is because there are a lot of international guidelines, a lot of consensus statements, good quality evidence for those already. So they are touching upon those effusions that are usually less touched upon. So with this beautiful statement paper, which is quite an exhaustive paper, I will be dividing my videos into sections to make it easier to absorb and understand. And with the first section or the first of these videos, I'll be starting with the general overall summary of what the statement paper offers. So let's get started. So to start with, this paper takes forward the understanding of non-malignant pleural effusions, starting with the Lights criteria. And you all would agree with me that Lights criteria is something which has been universally accepted, and they have been shown to be very efficient and very effective at not missing exudative effusions. So they do mention that Lights criteria have a very good um, sensitivity and specificity of identifying exudative effusions. But the specificity of Lights criteria sometimes gets affected. And this lack of 100% specificity, so to say, would result in misclassification of transudates as exudates. And this is pretty common in almost 25% of pleural effusions. So even though very highly sensitive and specific Lights criteria do exist, there's still a gap where just using the Lights criteria can misclassify the effusion. So there's a need to look at other alternative criteria. And so they say that to overcome this gap, the alternative tests that have been suggested have been reviewed, and there has been a systematic research of these tests. But when they have done that, they have still not found any particular test that could be superior to Lights criteria in detecting exudates correctly. So still, Lights criteria are ruling all the way. However, when we talk about effusions like heart failure related effusions or recurrent effusions in refractory effusions in heart failure, whenever Light's criteria do suggest an exudate, and we know that there could be a possibility of heart failure, they do recommend at the end of this statement that a serum to effusion albumin gradient is one test that you can do, which is found to be useful. And a serum to effusion albumin gradient more than 1.2 gram per dl is shown to indicate that you can accurately reclassify this effusion as a transudate due to cardiac failure and not misclassify it as a exudative effusion. The paper also highlights the importance of NT-proBNP levels. So serum NT-proBNP levels or pleural fluid NT-proBNP levels more than 1500 micrograms per ml have been reported to be accurate at diagnosing heart failure as the cause of pleural effusion. So this is something that we can use a lot clinically, because this is one test which we anyways do a lot in heart failure, and if we are to do that and the effusion is there, then it's almost certain that it's heart failure. Also, they mention that if we talk about liver failure effusions, then in the presence of a high pretest probability for liver failure, if you now do a pleural fluid to serum albumin ratio and it turns out to be less than 0.6, then it is confirmative of hepatic hydrothorax. Again, when your Light's criteria are ambiguous and they're not telling you the right discrimination and they are showing an exudate but you're suspecting a hepatic hydrothorax. So you can again use a pleural fluid and serum albumin ratio. Now, in case you don't have a serum sample available, then the statement paper mentions that you can use LDH. So, a pleural fluid LDH more than 67% of the upper limit of normal serum LDH, or a pleural fluid cholesterol, which is more than 55 milligram per dl absolute value, is reported to have a very high discriminative capacity to diagnose exudates, and this is equivalent to Light's criteria. So, this treatment is providing us with an additional criteria which is helpful in diagnosing exudates, and that is that if your pleural fluid LDH value is more than 67% of the upper limit of normal, or cholesterol is more than 55 in pleural fluid, then you may say that this is an exudative effusion. So these few criteria have been added to our knowledge with this statement, and it also talks about the other modalities of diagnosing and discriminating a transudative and an exudative effusion. Now, it also gives us a very exhaustive list of the currently most frequent causes of pleural effusions. And this is very helpful if you're a PG student, because it's important to recognize that although national data may vary, and the country and India that I practice in will have tuberculosis and infection related pleural effusions as a majority. If we look at the international status, and for the international listeners, heart failure occupies the majority cause, or the most frequent cause of pleural effusion in around more than 1500 studies that have been screened during this systematic analysis. And here they have also screened, they have looked at editorials, they've looked at guidelines, they've looked at retrospective studies, prospective studies, systematic reviews, meta-analysis, and based on all that literature search, they've come to conclusion that heart failure occupies the most frequent cause, followed by malignancy, pneumonias, tuberculosis, post-surgical effusions, pericardial diseases, and cirrhosis in that order. The most common cause of bilateral effusions, according to this data, is again heart failure in 53.5% patients, followed, or in some of the data, in some studies, it's also been renal failure in 23% of the patients. So, heart failure and renal failure, followed by malignancy in around 18% and pericardial disease in around 7% patients. They've also listed in a very good tabulated format, and PGs can take a screenshot of this, the causes for pleural effusions according to laterality, unilateral versus bilateral with its incidence. So this is different from our textbooks that we had because this is more updated. So if we talk about transudate, the common causes would be heart failure, liver cirrhosis, with less common causes being hypoalbuminemia, nephrotic syndrome, PH, volume overload, atelectasis, or peritoneal dialysis, and rare causes being SVC syndrome, constrictive pericarditis, urinothorax, CSF, non-cirrhotic hypertension, and extravascular migration of the CVC catheter. But in exudative effusion, the most common cause of exudative effusion is malignancy, pneumonia, TB, post surgical, and pericardial, with less common causes being between trauma, idiopathic, pulmonary embolism, abdominal diseases, autoimmune diseases, and uremic. And rare causes, as we already know, being chylothorax, esophageal, Meek syndrome, endometriosis, drug induced, sarcoid as a rare cause, amyloidosis, and so on. So it's a good distinction between the transudate, exudate effusions and based on which is more common, which is less common, and which is the rarer cause. Now, to differentiate between transudates and exudates, the statement very clearly mentions that the most commonly used criteria will continue to be the Lights criteria. And Lights criteria were originally conceived to maximize the detection of exudates because they wanted to reduce the risk of failing to diagnose a potentially serious condition like a malignancy or an infection. And so, Lights criteria, though they have a lower specificity, they have been mostly used, but you also need serum samples for a lot of ratios, and you are using cutoff values, which is something that may be a bit of a hindrance. So, alternative tests have been tried, but I said that nothing has been found to be superior than Lights criteria. So, the most commonly used criteria is Lights criteria with a sensitivity of 98 and a specificity of 72%, a positive likelihood ratio of 3.5, and a negative likelihood ratio of 0.03. So these are the original Lights criteria for your revision. A pleural fluid to serum protein ratio more than 0.5, pleural fluid to serum LDH ratio more than 0.6, or pleural fluid LDH being more than two-thirds of upper limit of normal serum value, meeting any one of these criteria will constitute an exudative effusion. So, what are the alternatives to light criteria? I have already discussed that the statement paper mentions that there are certain issues when we use light criteria. So, the alternates here is that if you don't have a serum sample available, as I mentioned in my summary, you can use an OR rule. With the OR rule says that if you don't get a pleural fluid to serum LDH ratio, you can use an absolute LDH more than 67% of the upper limit of normal and a cholesterol of more than 55, as I have already mentioned. Also, as I mentioned in my summary, when Lights criteria provide results which are close to the cutoff points and you can't distinguish, then if you have a high pretest probability, you can use for hepatic pleural effusions, you can use a pleural fluid and albumin, a gradient of serum albumin minus pleural fluid albumin of more than 1.2, or an albumin ratio, which is pleural fluid albumin divided by serum albumin of less than zero point 0.6, as almost 80% specific in reclassifying these effusions as false exudates and moving them to the transudate picture. The other criteria that I mentioned was NT-proBNP, and the alternative to identifying heart failure related effusions is the measurement of this natriuretic peptide NT-proBNP in the pleural fluid, or if thoracocentesis is not planned, it could be done in the serum. Both pleural fluid and serum NT-proBNP have a high sensitivity and specificity. So they did a meta-analysis in 2015 and they reported that a sensitivity and specificity of an elevated NT-proBNP in a cardiac failure-related pleural effusion was as high as 0.92 and 0.88 respectively. And if you talk about a pleural fluid NT-proBNP sensitivity and specificity, that was 94% and 91% respectively. If you look at the absolute values, then if the value is more than 1500, it is the most accepted threshold with a very high positive likelihood ratio of 7.8. So, in future, these could be taken with confidence as criteria to suggest a cardiac related pleural effusion. The other methodology of differentiating between transudate and exudate is imaging. So they've also looked at certain scoring systems and imaging guidance to differentiate between a transudate and exudate. And for that, the statement paper mentions a scoring system taken from Porcel et al.'s research on scoring to differentiate between pleural effusion secondary to cardiac failure in an exudative effusion. So here they've taken a few parameters, and remember, we're talking about the probability of cardiac etiology, but the effusion here is exudate. So how can you use a scoring system? A score system could include, according to Porcel et al., the system is age more than 75 years, giving a score of 3, an albumin gradient, which is your serum minus pleural fluid protein more than 1.2, giving a score of 3, a pleural fluid LDH less than 250, score of 2, bilateral effusions, score of 2, and a protein gradient, a serum protein minus pleural fluid protein. And I'm sorry, the albumin gradient would be the serum albumin minus pleural fluid albumin. So protein gradient, serum protein minus pleural fluid protein more than 2.5 will give a score of 1. And if the total score is 7 or more, then it has a great increase in the probability of a cardiac etiology. So this scoring system can give you a diagnostic accuracy of around 92% with a likelihood ratio, positive likelihood ratio of 12.7, and this will exceed the discriminative capacity or capability of just doing only a protein and albumin gradient in isolation. So the message here is that if you have a confusing picture and if it's a heart failure related effusion that you're suspecting, and your albumin and protein values, the gradients are not giving you a clear cut transudate and it is showing an exudate, then you can use the Porcel scoring system, where if you score age, you score the albumin gradient, the protein gradient, the absolute value of LDH being low, and being a bilateral effusion. If your score is more than 7, you can say with certainty that this effusion is secondary to heart failure. The other aspect that they've touched upon is how imaging could be used to differentiate between a transudative and an exudative effusion. So, when you talk about differentiating between these two types of effusions on an imaging modality, then the first parameter that one can use is obviously the size of the effusion, how massive the effusion is, because massive pleural effusions are usually seen in malignancies, they're also seen in pleural infections, usually exudative effusions. However, the authors note that even hepatic hydrothoraces can come with a sizable effusion. So, can we take this as a positive rule? We cannot. This is not an absolute rule. So, this will not replace the need for further assessment. So, if we are only distinguishing massive versus a more minimal effusion on imaging and looking at that for differentiating, then that is not a good rule. Let's talk about ultrasonography because ultrasonography has a tremendous role in pleural effusions and is used day in and day out now. We know that exudative effusions have a higher mean attenuation value as compared to the transudate. Can we use this parameter for differentiating a transudate and an exudate? The answer is no. We cannot use just the attenuation to be our answer for a transudate and an exudate on a CT scan. So, if we talk about CT scanning versus ultrasonography, CT scanning cannot really, with too much confidence, differentiate based on HU values whether if effusion is transudate and exudate. And what can help us is ultrasonography, which, as I said, is one of the most commonly used tools. So, when we do ultrasonography, the pleural effusions can be categorized as simple effusions or anechoic effusions or complex or hyperechoic effusions. And we can have in between them a lot of categories like complex non-septated effusions, complex septated effusions, and effusions that are homogeneously echogenic. Now, if you have an anechoic sonographic pattern, that means this pattern is mostly homogeneous, then you have a sensitivity of around 80% and a specificity of around 63% to say that it is a transudate. Now, when these transudates fall into a complex category, they can become complex, non-septated, mostly transudates, or sometimes you may also have septations within. So here, this parameter of looking at an effusion as septated or non-septated may also not be very, very specific to discriminate. So can we use echogenicity of pleural fluid alone to influence whether this patient has a transudate or an exudate effusion and whether we should aspirate this effusion? Echogenicity alone is questionable based on the literature to date. What are the characteristics of ultrasound then that we can use? Something like a pleural nodularity. If you get a pleural nodularity, it strongly supports the diagnosis of malignant pleural effusion with a good specificity of 96% and a low sensitivity of 42%. But then we can say that because there is nodularity, there could be a malignant pleural effusion. Now, when we were talking about CT scans initially, again, pleural nodules can be detected and pleural thickening can be detected by chest CT scans. So, if I talk about imaging in general, CT scans can give us a wealth of information about the degree of organization, the loculation of effusion, and these are more commonly seen in exudative effusions, but we know they are not exclusive to exudates. So, are these reliable parameters to differentiate between a transudate or exudate? The answer would still be no, but they are good parameters to use. Now, there's another imaging modality called MRI, which we are not often talking about, but the paper mentions that MRI can allow morphological and functional imaging of the pleura. So, MRI could be of value in detecting pleural malignancy and local tumor invasion, especially in mesothelioma. But does it have any practical applicability in determining transudate versus exudate? The answer is again no. There is no practical utility for that purpose. However, transudates are more often T2 weighted, hyper intense, and they return a low signal intensity on T1 weighted images. And there are also certain protocols like the diffusion weighted imaging protocols where they have ADC or an apparent diffusion coefficient, which will be lower in exudates than transudates. But in short, the bottom line is that no imaging can replace the biochemical analysis of pleural fluid in combination with clinical data. So you have to use clinical data to categorize it as a transudate or an exudate. So now when you are faced with pleural effusions, which are characterized by as an exudate by lights criteria, but you are not very certain, you can use certain scoring systems as the scoring model that I showed in cardiac failure. You can use imaging to try to understand the pattern of echogenicity, but is it reliable? No. And what you can best use is radiological finding along with the biochemical analysis to categorize the effusion. So with that, I conclude today's video. The second part of this video will deal about individual pleural effusions and throw more light on what I've spoken in this one. Stay tuned, do subscribe, like, and share this channel. And I'll be back with the second part of the ERS statement on non-malignant pleural effusions in adults. Remember, these are non-infective effusions. Thank you and bye-bye.